Okay, so thank you for inviting me to share a little bit about my world. My name's Julie Sarton. I've been a pelvic floor physical therapist for the last 24 years. I have a private practice in Orange County, California with 3 locations. And before I opened my practice about 11 years ago, I was at the university at UC Irvine in the university setting, and I got to work side by side with both OB-GYNs and urogyns and urologists, which was amazing. And so while I got to learn the medical side, they got to learn the musculoskeletal side. And so I loved being in that setting and having fellows come in and shadow me, which they made part of their urogyn fellowship, which was super fun. And so yeah, 11 years ago, I started my practice. We have we see patients with all forms of pelvic floor dysfunction. And that is, we're a specialty practice, and we get patients now coming in internationally. We've got 3 people here this week from various parts of the world. So let's dive in, and please feel free to ask questions as we go about anything. All right, so hold on. Okay, so I know I'm preaching to the choir. I always just like when I speak just to talk about scope of the problem. I know you're all aware of this, but we'll just recap really quickly. I mean, how common is sexual pain? It is so common. So we treat actually both women and men in my practice. These stats I don't think are accurate at all, but this is what the literature says. And so, I mean, I just threw up one here. This study by Herbenik, 30% of women suffer with sexual pain, 5% of men. In our practice, we see 40% male patients as well as 60% female. And those men are coming out of the woodworks, and they're finding us with not just sexual pain, but also pelvic pain. So 9 out of 10 women postpartum have pain with sex the first time they have sex after having a baby. That's huge. And still at 3 months, almost 50% are still experiencing pain. And then at 18 months, almost 25%, 1 in 4, are still experiencing pain. But yet no one's talking about this, right? Our OB-GYNs aren't talking about it. Our primary care doctors aren't talking about it. I'm so excited you guys are going to be talking about it. You're going to be asking your patients. Postmenopausal women, right? Very common, up to 30%. Breast cancer, up to 70% have sexual difficulties after they go through their cancer treatment. So super happy we get to keep talking about this. So I always like to ask too other practitioners, why do you think no one's really addressing this, right? No one's talking about it. Yeah, it's it used to be, and it's improving, taboo. There's a great study that I found that looked at out of 2016, and they looked at 150 doctors and asked them if they were addressing sexuality in their practices. Okay, almost 65% said nope, nope. And then they dove into, well, why is that? Well, lack of time, just with the medical model now, fear of embarrassment, and then just the inability, like, I don't know how to address this. So, you know, we get in my practice, we get patients that have been bounced around, honestly, that have seen anywhere from like 3 to 10 different practitioners. In fact, gosh, about 3 months ago, we had a patient who literally saw 40 MDs to get her diagnosis that was rooted in the musculoskeletal system related to her endometriosis pain. 40 doctors. So that's why I'm super excited to just even have this opportunity just to keep preaching and talking, because we need to change those stats. All right. So these are some of the statements that we have had from our patients over the years. After 40 years, we still haven't consummated our marriage. That is not made up. That is not a joke. That was one of my patients. More commonly, we'll hear 3 years, 5 years, right? We get patients not just with, you know, dyspareunia, but also apareunia. So this was a case, the 40-year-old or the patient with a 40-year history of apareunia who came to me from a sex therapist. And, you know, she had struggled and struggled. And this was probably about 18 years ago when this patient was referred into me. And, you know, and thought it was all in her head, right? That's what she had been told, that generation for sure. And she found a brilliant sex therapist who listened to her symptoms and said, you know what, I think it's in your pelvis. And she came in, and we're going to talk about what we found related to the musculoskeletal system tonight as I go through that, because my goal is for this to be on your radar and for the pelvic floor musculature to be part of your differential diagnosis with any patient walking in through your doors. So some of these other quotes, these are things that patients that I've seen over the years were told by physicians or healthcare providers. Oh, there's nothing wrong with you. I suggest you get liquored and lubed. Ah, it's in your head, relax. Oh my gosh, we can't find anything with the exam. Go home and rent a good adult movie. Here's the number to a psychiatrist. Why don't you call and make an appointment? And then this last patient, I mean, it still actually almost brings tears to my eyes. So she had severe vulvodynia, which that's a whole nother topic, but so vulvodynia, she was told by a urogynecologist that is in the community, he actually treats a lot of patients who have cancer. He's like, you know what? I have patients with cancer in my waiting room who worry about dying. Your problem is minor compared to that. And this patient responded, did you know the pain is so bad at times it makes me want to die? And this patient, she couldn't wear underwear, she couldn't sit, let alone have sex. So these are the stories that come through. So early signs of sexual pain when we think of the musculoskeletal system would be just explore these with your history, right? So pain with tampon insertion is classic, right? That these are all red flags, red flags. Pain with a gyne exam, right? Discomfort wearing either tight clothing or underwear. Sometimes the seam in jeans or tighter pants will bother and irritate people. History of painful periods and all these pelvic pain syndromes that exist. And I'm not sure if you have exposure to all the different diagnoses. We'll kind of look at that. Obviously, any perineal pain or pain with sitting, these are other common things we see as red flags. So I'm going to skip over this pretty quickly because I'm sure you guys are pretty great with expert training and you know the questions to ask to really help identify the cause. You know, if you get these this patient referred, well, or these patients are coming in, right? So we want to always go back and figure out, like, what was that event? What was, and the patient will tell you usually. And we're going to talk about, like, specifically with the pelvic floor, why this is so important, because so commonly when our patients come in with sexual pain and pelvic pain, they're surrounding, this event has been surrounded by some big event, whether that was trauma that happened physically or a big emotional trauma or a financial issue. And we're going to talk about why that turns on the pelvic floor, and then that can drive sexual pain. So coming in just a few seconds here, let me just get through. I know you're all familiar with the symptoms of painful sex. So these are the common things, and we listen for descriptors because it helps guide us as we're thinking about, is this muscle related? Is this hormone related? Is this nerve related? What is it, right? So sharp, right? So example, this was one patient that told me it feels like there are knives there all the time, right? Good days, it's like paring knives. Sticking me on bad days, they are butcher knives. So sharp always makes me think immediately from the muscular perspective, what's happening? Bruised feeling can be myofascial pain, rawness like an open wound, stinging on fire, burning, right? I'm going to think more potential nerve, right? Or hormonal insufficiency, itching, right? I may think histamine, swelling. We're going to look from a lymphatic standpoint too. And then looking at both, is pain superficial and deep, or maybe a combination? And then also what's happening with things like we talked about, like tight clothing, sitting, you know, is pain exacerbated by certain activities such as riding a bike? So when we look at trying to figure out what is our differential diagnosis, what are the causes that set the stage for pain with sex, right? You guys know the medical side beautifully, right? So you're going to rule out infections. We're going to look for a history of trauma, injuries, whether that was a physical trauma with childbirth, a surgery, maybe a split fall, maybe a fall into the tailbone. And then we're going to also look at, obviously, any sexual pain condition or pelvic pain condition. And there's an overlap between these. So the big ones are that we don't have time to go into tonight, but vulvodynia, vestibulodynia, huge. interstitial cystitis, known as painful bladder syndrome, pudendal neuralgia, endometriosis, and with our men, chronic non-bacterial prostatitis. So obviously you're also looking at hormonal changes, skin, you're ruling out skin conditions, scar tissue, inflammation, cancer history. But what is the one thing that is missing on this list, right? So you may be like, yeah, that's a nice, extensive, comprehensive list. What is missing? And what do I want you guys to add into your differential? It is the musculoskeletal element known as the pelvic floor muscles. So I always like to call these muscles the forgotten muscles. And I also like to call them the great deceiver. And why is this? Because these muscles can manifest what are known as trigger points, so top bands within muscle that can create referral patterns to other areas of the body. The patient may not necessarily feel where the pain is coming from, right? So very commonly, you can get referral patterns from the pelvic floor that extend up to the lower abdomen, mimicking menstrual cramping pain. You can get common referral to the low back, whether tailbone pain or the lumbar spine. You can get common referral over to the hip. These muscles also can mimic organ-based pain. So it's not that uncommon that patients will say, oh my gosh, I feel like I have urethral burning pain, right? And it might not be the urethra itself. The urethra may be the victim, and the pelvic floor, the urogenital diaphragm muscles surrounding the urethra are the problem. So these muscles can mimic ovary pain, GI, any essentially prostate pain or symptomology. So when we look at these muscles, collectively, we call them the pelvic floor muscles. We know they have 4 big purposes. So sexual functioning is one of them. The other ones include a stability function. So really these muscles fire with every step we take. They're working with our deep abdominal muscles, our low back muscles, and there's a pressure relationship with the respiratory diaphragm and the pelvic floor. So when we take a deep breath in, the diaphragm descends and the pelvic floor descends. And when we exhale, the diaphragm rises and the pelvic floor rises. So even the way we breathe will influences the function and state of these muscles. So we've got sexual functioning, we've got a stability role, we've got a supportive role. These muscles have to help hold up all the organs. And then we've got a sphincteric role. These muscles help create and play a role with continence, both with bowel and bladder. So I am going to turn on, let me just see your faces really quickly, or anybody. Does anybody routinely, when you're getting patients coming in through your doors, do you assess the pelvic floor? If anyone wants to chime in and say yes, no,
Yes.
Yes. Yay. Got one yes. Anybody else? You're like, this is part of my screen. I'm just curious if this is happening in your training. If you're like, I know all this.
Yes, we do.
Okay, beautiful. So, and you feel confident too on how to do a muscular exam?
To be honest, I think a muscular exam for me is a lot easier on a woman than it is on a man.
Okay. So, if you reach out to me, I have a video that I could send to you too, where I walk through. There's a model right here that you can see. And I just walk you through on the model, like how to quickly go through it. It is a little more challenging on the male, obviously, since you're going in transrectally, transanally, but it's all the same musculature, right? So same anatomy, and then obviously the same nerve. It's just the genitalia that's different. And it is a little more challenging just because of the tension usually of the external anal sphincter. But I
do you mind sending that to all of us?
What's that? Oh yeah. I'd be happy to send it to all of you. Yep. And I think really, as you go through with the exam, is that if you don't know the complete lay of the land, if you can at least pick up what happens with the superficial pelvic floor and even the first layer of that deeper pelvic floor with the puborectalis and the iliocostalgius muscle just right inside, that's enough for you to be able to figure out, does this patient have with the presentation a hypertonic pelvic floor or hypo? And sometimes it'll just take, feeling about whatever, 50 different patients where you're like, yep, bingo. And you'll pick it up super fast. So, a hypertonic pelvic floor, when I teach, I always teach like it's very similar to if you come up and feel your upper trap here. I mean, most of us will find either a top band or a trigger point within this area. We push it, it hurts. Sometimes it creates a referral pattern. There's a whole book out there called A Headache in the Pelvis that was written, a beautiful chapter on the lay of the land of the pelvic floor and these muscles and their referral patterns that I was talking about, right? So it's the same thing. These muscles are skeletal muscles like every other muscle in your body. The only difference is, which we were talking about earlier, is that these muscles are governed by your autonomic nervous system. So when we go back and we're like, what event can you're asking your patient, can you correlate the onset of your symptoms with, a lot of times there is some big stressor that has happened in their life. They may not remember it immediately, but usually then they'll go back and piece it together. And it is interesting, just over the last 2 years, we have seen such an uptick in our patients because of the pandemic. I think number one, the stress levels are on a different level for people. And number two, everyone's also sitting, chronically sitting, right, in front of their computers. They're working from home. They're on their sofas or whatever for like 8 hours, 9 hours, and their pelvic floors are being compressed. So, but yeah, with knowing that these muscles are governed by that autonomic nervous system, the more time we spend in fight or flight, the more that pelvic floor gets turned on, and physically nothing needs to happen. They did a very interesting study quite a few years ago where they looked at women who manifested a hypertonic pelvic floor, and they did needle EMG monitoring what happened with the pelvic floor as well as adjacent external muscles. And all they did was show a scary scene of a movie or ask these women to do difficult arithmetic, and the electrical output shot up within the pelvic floor, but yet the adjacent external muscles stayed quiet. So it's a great study to reveal like, oh my gosh, yeah, we know what happens here influences this. And I'm careful when I educate patients about this so they understand part of the treatment becomes like, we got to go down regulate your nervous system, and we got to teach you and make sure that you are integrating some kind of strategies to get into that parasympathetic state, right? We call it down training. Because we know, or as the patient, that this process will perpetuate your pain. But I'm careful to make sure that I don't convey the message that I think it's all in their head, right? But the head mind body component is huge. So when we look at a hypertonic pelvic floor, we always go, now we want to go one step further. And we're like, okay, well, so this patient has it. Well, why do they even have it? And I always love to ask the question, is the pelvic floor the driver, or is the pelvic floor the victim with the muscular system, right? So is there an underlying biomechanical dysfunction? So these are 4 broad categories that set the stage for a hypertonic pelvic floor. Is there something like a scoliosis or SI joint dysfunction, or do they have chronic faulty posture? And there is something known in the literature as the typical pelvic pain posture with an increased lordosis. It's essentially like the pregnancy posture. Increased lordosis, anterior pelvic tilt, compensatory kyphosis of the thoracic spine, right? Or even what happens like just with pregnancy. Or was there something that happened, like the injury we talked about, right? So was it after a birth, whether C-section, vaginal birth, maybe a big fall, a pelvic surgery that happened? Or is there an inflammatory underlying pain disorder going on, like IC, endo, IBS, and through this chronic noxious stimuli coming back up through the sacral plexus into the sacral cord, that we get this dysregulation that starts to happen with the muscular system as an output through that level of the cord. And then lastly, what are our patients doing? Do they have any unhealthy like dysbehaviors, right? Are they constipated? Are they straining to poop? Are they, like we just talked about, sitting for 8-9 hours a day, not getting up or maybe getting up once, right? Are they not breathing properly now that we know that there's a relationship between what happens with the diaphragm and the pelvic floor? Are they just holding, right, patterns because of stress, anxiety, or I had this one patient that had recently, she's like, I hate going to the bathroom in public places. So she won't urinate at all during the day. She holds her bladder for about 8 hours because she said the bathrooms aren't clean enough at work. Well, pelvic floor isn't designed to work like that either, and to be in a constant, quote, Kegel state. So hypertonicity essentially means that the muscles are shortened. So if my bicep is my pelvic floor, right, I walk around with too much tone at rest. So the muscle becomes essentially shortened and almost develops a contractured position, right? So a healthy muscle needs to go through its full range of motion. By the way, I generate the most amount of strength if we look at a length tension relationship with muscle physiology, actin and myosin cross bridging that happens. You go way back to muscle physiology in med school, right? What happens is maximal amount of force is mid-range right here. So we get all these patients coming in, most of our sexual pain patients and pelvic pain patients, they have these hypertonic pelvic floors that are here. They're already in a quote Kegel position, right? So unfortunately, what happens out there is these patients then are told either by PTs or MDs or what in the fitness industry, like, oh, you got to strengthen, you got to just go after your pelvic floor and you got to Kegel, right? And they're not going to develop any kind of strength. All they're going to do is reinforce that true shortening and that actin myosin cross bridging that is literally stuck. And that's that palpable trigger point that we palpate within the muscle. So what are side effects then of the pelvic floor? We talked about all the referral patterns to the hip, the back, right? Other things I want you to think about would be, especially as urologists, UTI-like symptoms. So common. We get a lot of people that come in, they're like, oh my gosh, I have recurrent infections. And then I'm like, well, okay, how many of those were cultured? Oh, they weren't. I just was thrown on antibiotic after antibiotic, right? We actually had a male patient that literally who was diagnosed with chronic prostatitis was on antibiotics, no kidding, for 1.5 years. And he got to us and it only took 8 visits to start pulling down his symptoms, 8, because it was all manifested and rooted in his pelvic floor musculature. So UTI symptoms, urinary urgency frequency, outlet constipation. Think of, it's not just what's happening with the bladder, but on the backside too. These pelvic floor muscles surround the external anal sphincter and the anal canal, and they need to be able to eccentrically release so that we can defecate. They need to be eccentrically able to release around your urethra so that we can have a really nice strong urine stream. The neck of the bladder can drop down and we eliminate really beautifully. And then obviously what we're talking about mostly tonight is pain with sex. So I'm super excited. You guys actually said, yay. So a few of you that you're performing, or maybe all of you performing a pelvic floor muscle exam. When I used to lecture at UCI, I would do grand rounds once a year and I'd go and stand up there and talk. And I'd always ask, how many of you look at the pelvic floor muscles as part of your annual exam? And the 3 doctors I worked with every year would just raise their hands and everyone else had their hands down. So it's really exciting, since I've been doing this for a while, to see that this is becoming, the goal is that this will become standard of care and that every single patient would just get, the pelvic floor muscular component evaluated and addressed. So we could try and capture these issues and dysfunctions ahead of a major problem happening. So getting to know your anatomy, I will send you the video. Most patients have no idea about what their anatomy is, let alone a lot of providers out there. Some other thoughts that I have about why is sexual pain or even pelvic pain due to what we call pelvic floor tension myalgia or a hypertonic pelvic floor hard to diagnose? Well, because really, you're getting it in your fellowship training, which is awesome, but mostly you're not getting it in med school. And then the other thing is symptoms. The way that the pain is transmitted through the spinal thalamic tract the pelvic floor afferents come up through the medial thalamus versus the lateral. So it's really hard with pinpoint discrimination on the brain. That's when patients are like, I think it hurts over here, but I don't necessarily know. And then we already talked about all the referral patterns too. That makes it very confusing for both patient and practitioner. Okay. So with pelvic floor PTs, my goal tonight is that if you're not already yoked up, hopefully you guys are with 1 or 2, that you go find one in your community, because this becomes part of the multidisciplinary team and it's such an essential piece. And so really, I like to quickly outline what is pelvic floor PT, because the big misconception is that we are personal trainers for the pelvic floor. Like, we're going to teach our patients to Kegel. Well, most patients that are coming in to our practice with sexual pain and pelvic pain have that hypertonic pelvic floor. So it is not that we are teaching them to Kegel. In fact, that is contraindicated. So I'll take you through a few quick examples of patients so that you guys can see some quick cases. But we're going to address all the functions of the pelvic floor: sexual dysfunction, stability dysfunction, sphincteric, right, and supportive. And so I want you to think of then what would be a green light to refer over to PT. Well, signs and symptoms of a hypertonic pelvic floor that we went over. If you're working your patients up and they're coming up with negative cultures and labs, I want you to think, even if you're going to do a surgery, how about prehab? What do we do with patients that are going to go have an ACL repair with their knee, right? They're sent to orthopedic PT. So it's no different with the pelvis. So I would love you to start considering pelvic floor PT before and after any kind of surgery. And then if you're just hitting a wall and there's no response to traditional intervention that you're doing from your medical management side. Okay, so I'm going to quickly go through 3 little cases very fast. There's a couple take-home messages I wanted to share with you. So this patient, his name was Cade. He came in here to see us. He had testicular pain. He had sexual pain, tailbone pain, penile burning, particularly at the glans penis, and he couldn't sit for functional time periods. And why I wanted to point out Cade's case is I want you to look at that second picture, and do you see this large scar coming through from the sternum all the way down to the umbilicus right here? So this was because he had had multiple surgeries for a congenital heart issue. And so this fascia right here, no one had ever touched this scar. And he came in, and when we worked with this scar, it referred all the way down into his pelvic floor and helped reproduce some of his symptoms. So the abdominal wall fascia is continuous with the pelvic fascia. So we want to have our patients take off their shirts. We want to look outside the box, literally. The other big thing is that he manifested, when we look at what sets the stage for a hypertonic pelvic floor, you can see he has a scoliosis, and he's got this nice postural dysfunction going right through here. And so the scoliosis was creating also a leg length difference. So with every step he was taking, his legs were unlevel, and we had abnormal forces coming up through what we call the lower kinetic chain. He had had multiple falls. His tailbone was off to one side and rotated, and all of these things needed to be addressed besides us just going after, treating his hypertonic pelvic floor internally. So we're casting a wide net. So take home message with this patient, Elias. He actually came to us from Greece. So he was diagnosed with prostatitis, and he had pudendal neuralgia symptoms with penile and perineal burning, pain with ejaculation, and sitting bone pain. And here is his map over here of what's happening. You can see with his superficial pelvic floor muscles. So we have the transverse perineal muscle here, that he was having symptoms of this burning sensation. We know that the perineal branch of the pudendal nerve runs right through this muscle. And then we have his ischiocavernosus muscle that also was irritated right in through here, and his bulbocavernosus as well. And so we know that another terminal branch of the pudendal nerve that goes down to the tip of the penis to the glans penis actually runs through here. So we had to treat and assess all of these. So this would be something to think about as you do your exam, is you manually want to palpate these external muscles. You don't even have to do an internal. You can already get an idea of what's happening just palpating these 3 muscles right through here. So Elias, he essentially, when he started experiencing symptoms, this all started because he wanted to improve his ability to have a really strong erection. And so he was like, I'm going to just start Kegling. And so he started doing like 60 to 80 Kegels a day. Well, unfortunately, Elias already had a hypertonic pelvic floor. He didn't walk around with pain. It was subclinical, but this tipped him into symptomology where it put too much compression around his pudendal nerve. He went and saw a doctor. The doctor told him to literally drink wine and let it just go away. With time, it'll go away. Then he saw a pelvic PT there who just instructed him to do more Kegels. So neither of these obviously worked. And fast forward, we were able to treat him. He came in for an intensive with us for about 6 weeks, and we were able to help pull all his symptoms down. Okay, so a female, let's quickly look at. So this female came in to see us, Katie, and she had left lower quadrant pain. And we ended up getting a diagnosis of endometriosis, painful periods, and pain with sex. So her pain actually wasn't just the sexual pain, but the lower quadrant pain was so severe that she ended up going to the ER every month. So finally, a doctor was like, you know what, let's go and do exploratory laparoscopic surgery. And that's when they found mild endometriosis. They removed it. And within 48 hours, her pain was back to 8 out of 10. And at that point, the physician said, we removed the pathology. It's in your head. So she read an article that I wrote and she referred herself in. She's like, is this what I have? And so what I wanted you to see about her story really quickly is, again, postural dysfunction. So if you can just look at your patients, I know they might already be sitting or on the table when you're coming in, and you might be limited with time, but if you can have them stand and just take a quick peek at what's happening. So she's got that typical pelvic pain posture. And if you look at the middle picture, she's standing like a duck, right? So she's standing in external rotation. And so can you guess what she did? What was her sport that she did? She was a ballet dancer. And standing in this position, so a lot of gymnasts and ballet dancers get into trouble later. This sets the stage for 2 hip external rotators, the obturator internus and the piriformis, which are associated pelvic floor muscles, to be short and tight. It'll cause the levator ani muscles to definitely hunker down and stay hypertonic. And so I looked at her, and even before palpating, I already knew what I was going to find. I'm like, uh-oh, those muscles. So if you can look at the last picture, so we see a picture of the white line right here, arcus tendineus levator ani, and we've got the obturator internus, and that is covered the lower 2/3 by the iliococcygeus. So with this patient, when I did her internal pelvic floor exam, I went right to these muscles, bingo, we reproduced all her lower quadrant pain. We reproduced her pain with sex and her dysmenorrhea, right? Menstrual cramping pain. So we were able to successfully go after that. All right. Okay, so what happens when the patients come and see us? So you get a better understanding. I'll quickly walk you through that, and then we'll open it up for some questions. So pelvic floor PT treatment, education is really big. So we really start with pain science. If pain has been around for a while, we know that chronic pain is very different than acute pain. It only takes 3 months of pain to be considered chronic. So there are a lot of different processes that happen with that. I don't have time to go into it tonight, but we do, the take-home message for that is not only do we need to look at the pelvic floor, but we need to look at changes that happen within the spinal cord, and we need to look at changes that happen with certain firing patterns that exist on the brain. So educating patients about this is huge. And there is literature and research out there to show if you do nothing else but educate on the principles of pain science, a year out, they'll already have about a 25 to 30% drop in their pain syndrome, whether sexual pain or pelvic pain. So we do a lot of education on down training, like we talked about, to help that nervous system get into the parasympathetic state. We teach them how to self-treat, and we'll show you some examples of that. We educate, if they have a partner, on how to work with them, both externally and internally. We do postural re-ed. We work on educating on breathing, toileting techniques. I'm sitting here with one of my PTs who's supposed to be a patient right there, reviewing how do we actually go to the bathroom, right, to help the pelvic floor stay in a really healthy state. No Valsalva voiding. This is a squatty potty right here that anatomically puts the pelvic floor in a beautiful position to help lengthen and open it up. And then we do graded exposure. Like if they have pain with sex, we're going to expose and get them to self-treat with tools like dilators or wands in a very graded manner. So the mainstay of what we do as pelvic PTs then is we look at integrating advanced manual therapy. And we do this both inside the box and outside the box. So when we do our manual treatment, we always treat in terms of layers. We're thinking skin and the fascia, connective tissue right under the skin. And how dysfunctional is that? And we know that the fascia is continuous through the body, and the fascia itself can be a huge source of dysfunction and pain. And after we go through that layer, we go into the muscle. We look at what happens with the pudendal nerve, the main nerve that innervates the pelvis, and even genitofemoral, ilioinguinal, iliohypogastric coming from the lumbar spine that's also innervating the pelvis. And then we look at bony structure and alignment, and then always consider systemic drivers, underlying things that would promote more muscle spasms, such as hypothyroidism, or maybe a vitamin B deficiency. And these can be underlying perpetuating factors as to why our patients have muscle hypertonicity and muscle spasm. So then we start to integrate and treat with our hands. We start our treatments always externally, and then we move to internal treatment. Here are some examples of some tools then that we teach patients how to self-treat with. So these are different dilators, and there's pelvic wands as well. And many times we'll also recommend that some of our patients with significant hypertonicity also can use suppositories prescribed by you all that can be a combination of different meds, whether it is Valium or baclofen or cyclobenzaprine, that can be integrated. We educate about vaginal lubricants as well, and looking at, those lubricants that are containing either propylene glycol, which can burn, or glycerin. And we want to watch what is happening and teach patients how to read labels. We do a very nice integration of exercise as well. We look from both what patients can do just on the go, like integrating with their posture, as well as just coming up with a nice routine. And the goal is to always lengthen the pelvic floor and rebalance and wake up some of the other muscles to offload the pelvic floor, so that that we get really nice, what we call force closure through the pelvis. So these are some other examples. So the patient isn't just passively lying on the table when they're in our office, they're actually working as well. And that's very empowering to them. And then some other adjuncts that we have, we look at using a class 4 laser, which is one of our most popular things. It flies around our clinic. It definitely brings down immediate pain. It's a photochemical reaction that causes beautiful blood flow to enter into the tissues, the muscles, and then actually helps with mitochondrial stimulation on the cellular level. We can use biofeedback, not a huge fan of it, but it is available, cupping. And if patients really have refractory pelvic floor muscle spasm, then we can coordinate with you as a physician to look at even Botox to the pelvic floor, or even certain blocks, either with you or a pain management doctor. So really, like when I look at like the anatomy of a pelvic floor, PT, a good PT. So when you're looking in your own area too, please screen and just have a talk with them, because there's a wide variety, and you want to look for somebody who definitely has experience, not just taking a weekend course and hangs their shingle. But the key things you're going to look at is, are you doing both internal work, if you are working with female patients, both vaginally and rectally? Are you teaching your patients how to self-treat? Do you really understand what's happening with the pain science principles? Are you looking outside the box? Or are you just doing a 15 to 20 minute quick treatment internally? Somebody that's going to help you really put the pieces of the puzzle together, because some of these patients are very complex. They don't come with just one issue. They're presenting with 5 or 6 different ones. So, so just another detective to help you on the team. All right, if you guys have any questions, feel free to reach out to me, Julie at Pelvic Healing. If you're an Instagram person, please hop over and follow us if you do that sort of thing on Pelvic Healing, and our Facebook, or Sarton Physical Therapy. And if you're looking for a PT, just use Google, look at mypelvicfloormuscles.com. It's another great resource. Pelvicguru.com is a great resource as well. And then the American Physical Therapy Association has a specialty section that can help you find a provider. All right, that is it. Any questions at all? Oh, thank you. Thank you, Justin. Okay, if there are no questions, then I'm going to turn it over to Dr. Stan.
Okay. Oh, there we are. Hi, so I hope you can hear me. If not, Bobby, jump in and let me know because I'm just seeing the screen in front of me. So I am a clinical psychologist and I'm the executive director of the Center for Marital and Sexual Health of South Florida. And I'm an emeritus professor of Case Western Reserve School of Medicine. And I'm currently living in West Palm Beach, Florida. So here are some disclosures that we need to give, of course. I'm either a consultant, a member of an advisory board, or a PI to these companies. And what I want to talk about is very much like what Julie did, which is combining treatment modalities is often best for our patients. We tend to learn, I learned clinical psychology, you all are learning urology, and generally we stay in our, the lanes that we were taught. We don't cross over, and we're not too much on mixing modalities, although that is becoming more popular. But clearly, as we've seen, it really is often best for our patients to mix medicine with physical therapy or psychological intervention. So I thought, because this is relatively informal, I'll tell you a little bit about myself and you'll see why that is. So I began in the Department of Psychiatry at Case Western in the late 70s, and I had joined the Sexual Dysfunction Clinic in the Department of Psychiatry. That's what we called it then. And in the 80s, we developed other programs for gender dysphoria, which at that time, that's what we called transsexualism or trans. Then we began programs on sexual compulsivity or out of control sexual behavior. And then we developed for licensing boards, professionals who crossed boundaries, physicians that engaged in sex with patients, psychologists who engaged with sex with patients, and we saw clergy as well. So what I learned from this was my urology colleagues would say, hey, did you see Mr. So-and-so? I referred him to you. And it became clear that only 10% of patients who were given our names for some therapy ever came and called us. And this led us, this was rather unsatisfactory to the urologist. It was unsatisfactory to the mental health person. And it led us to a joint venture between psychiatry and urology that we called the Male Sexual Health Center, where 2 mornings a week, that is in the same space, the urologist and 2 or 3 mental health professionals and nurses saw the men with sexual complaints. That is, we would see them, he might see them first, I might see them next, she might see them, we took turns and we spoke in between so that we could develop a treatment plan on the fly. It was also really helpful for developing a database on our patients. And that led us to produce, this was all pre-Viagra. We were some of the first people to produce a series of papers on intracavernosal injection and vacuum pump therapy. It also led us to develop patient-reported outcomes that were used in the Viagra and Cialis trials, such as the EDITS, the Male Sexual Health Questionnaire, the SEER, the IPE, so that we did these things sort of, they came naturally because we were working together. And my life changed in 2004. I moved to Florida and set up a private practice in West Palm Beach. And here, there really is little coordination between urologists, gynecologists, and mental health clinicians. It was very different than the male sexual health center, or my colleague, Cheryl Kingsburg, who's a professor at Case Western, is in the Department of Reproductive Medicine, does the same thing that I did in the male sexual health center for women. So you've probably seen this slide before, but it's really important. That is to think not just medically, but to think in a larger picture. What's the biology of our patient, their physical health, neurobiology, endocrine function, blood flow, etc. The psychology, what are the issues that this is related to? Performance anxiety, depression, history of sexual abuse, issues in the relationship, the quality of their current and past relationship. Many men come see me who haven't been sexual in 5 years. And so the interval of abstinence is really a big issue, and it's a large hurdle to overcome. Other things like life stressors, finances, and the sociocultural issues. I see people in arranged marriages, and that has its own sort of interesting history. The reason I present the biopsychosocial model is that it captures, and this is the important phrase, the ever-changing influences of biology, psychology, relationships, and cultural issues. So that if there's a medication that's given, that could change all the issues. If there's a surgery that the person undergoes, or chemotherapy, or if there's an infidelity, all of these things change in the biopsychosocial model. And it emphasizes the psychological impact the dysfunction has on the individual, the couple's sexual equilibrium, and the fluctuating influences of medication, lifestyle, and disease. You probably know this better than I do. What's the impact of a prostate cancer diagnosis? Clearly, it can be difficult and distressing, both for the patient and loved ones. And again, you know this, when patients hear the word cancer, they immediately associate it with death and dying. And they then begin a difficult journey, whether it becomes watchful waiting, or electing to undergo a radical prostatectomy, or choosing chemotherapy, radiation, or hormonal therapy. Any of these tend to have unwanted physical, sexual, and emotional impacts that are distressing to the patient and partner. Also, patients experience alterations in their sense of themselves. Now they feel, I've lost my masculinity, I'm old before my time, I'm frail, I'm tired all the time. And this is very different in community settings, like I'm in now, where generally after a treatment intervention, except for medical follow-up, the patient and family are all alone. We don't have programs here to help patients or their families with trying to overcome some of the issues after radical prostatectomy or radiation therapy. And you all know this because you come from sophisticated programs, you're fellows. The compliance with ED treatment or penile rehabilitation programs is poor. Men find themselves in what we call a cycle of avoidance related to ED treatments. That is, everything's changed for them. Now they're anxious, frustrated, disappointment, and as it relates to ED, and they avoid sexual situations, and they avoid the use of ED treatments. You know that 50 to 80% of men discontinue medical interventions for ED, whether they're the pills, penile injections, vacuum devices. Within 1 year, 50 to 80% of people stop. I'm going to show you a program developed by my colleague, Chris Nelson at Memorial Sloan Kettering, that addresses some of these issues. But again, let me start with the larger picture of who conducts sex therapy and what does it address. So generally, this is a mental health clinician, a clinical psychologist like myself, a psychiatrist, a clinical social worker, or marriage and family therapist. But in graduate school, we had no training, and some have slim amounts of training in sex therapy. So you need to find a colleague who has some specialty or special training in sex therapy. What do we address? We address for the male low sexual desire, ED, genital pain, ejaculatory dysfunction, premature or delayed ejaculation, and issues of pleasure and satisfaction. And for our female patients, female sexual interest and arousal disorder, orgasmic dysfunction, female genital pain, genitourinary syndrome of menopause, and issues of pleasure and satisfaction. However, we also deal with distress from medical conditions that affect sexual function. Or we deal with out of control sexual behavior. I deal with identity issues, and we deal with relationship distress. So that's sort of the larger part. Again, I thought it'd be interesting just to very quickly tell you about Chris Nelson and program, John Mulhall at Memorial Sloan Kettering. They developed an acceptance and commitment group psychotherapy. And I'll show that to you on the next slide in a second. They took 53 participants who were randomized to either the ACT, that's acceptance and commitment therapy, versus enhanced monitoring. Over 4 months, patients received 4 in-person sessions and 3 phone calls. Those in the enhanced monitoring group received 7 phone calls from an experienced sexual medicine nurse practitioner. Participants were assessed at study entry, 4 and 8 months, and the outcomes were the number of weekly injections, the edits, the Sears scale, and the Center for Epidemiologic Studies of Depression. I'm not going to read this very busy slide, but these were the agenda for session 1, 2, 3, and so on. It got people to accept where they are in their sexual life and to commit to overcoming this, not to avoid, which they had been doing, but rather to commit to getting better. And the success would be 2 or more injections per week over a period of a year, and more, how do I say this? Satisfaction based on the edits, and more feelings, that is improvement based on the SEER, and also looking at their depression. So the results of the ACT pilot study, ACT was the treatment group, EM stands for the enhanced monitoring. So patients in the ACT group injected 1.7 times weekly compared to less than once in the enhanced monitoring. There were significant differences. The men in the ACT group made the twice-a-week injections. 44% of them were compliant with that compared to 10%. Again, this is better. That's not all there is. And Dr. Nelson has further modified this and has even better results. This is the pilot study, and I know he's published the results of his ongoing study. It was an R01 grant that he got. Again, what is sex therapy? What is it that you think I do in my consultation room? So it's a specialized form of psychotherapy. That is, it's not just behavioral interventions, but it does draw on an array of technical interventions such as sensate focus, stop start, known to effectively treat male and female dysfunctions. We can do this in an individual session, in couple sessions, and even in group formats, depending on what we think the problem is and what would be best for the patient. However, a lot of people think of sex therapy as, oh, this is just like, sensate focus, or this is stop start. But I want to give you the message that the patient brings with them their family history, their health concerns, their culture, and their relationship issues. So you have to be a trained clinician, not just prescribe this sensate focus or stop start, because otherwise you're dead in the water. You need to have a larger and broader perspective. In this broader perspective, Cheryl Kingsburg and I give a lecture called It Takes Two to Tango. And the purpose of this lecture stems from what Masters and Johnson said in the 70s. They said there is no such thing as an uninvolved partner. And they use the word in a marriage where sexual dysfunction exists. Today, we'd probably say in a relationship where sexual dysfunction exists. And this is that by and large, we tend to see the man or the woman who comes in with a sexual complaint. And the partner's role is overshadowed by our looking at the patient in front of us. But what you need to know is that there's a dynamic and reciprocal relationship of one partner's sexual dysfunction or function, sexual satisfaction, physical and mental health to the other partner's sexual health and satisfaction. So for instance, let's look at this as partner one is the female, partner two is the male. She has a sexual pain disorder. There are several studies that will show you that men develop premature ejaculation when their partner has a sexual pain disorder. You could say this as a kindness, that is, as an accommodation. They learn to have intercourse quickly and then condition themselves, even when the pain goes away, to have PE. Or men who have PE, the partners tend to have hypoactive sexual desire disorder because it's not a lot of fun for them when the man lasts 30 seconds in intercourse. And again, all of these dysfunctions tend to bounce off the other. We tend to call this sexual pinball, but it's the idea of one person affecting the other. Or I tend to use the term sexual equilibrium, which is like a sexualized version of Newton's third law of motion. Any change in one partner will produce a change in the other. So let me take you through sensate focus and why we prescribe it. You have a man, whether he has a basically biological or basically psychological erectile dysfunction or a mixed erectile dysfunction. The man has a great deal of performance anxiety. He's worried, will I be able to keep an erection? Will I disappoint my partner? Will she be angry at me? Will I embarrass myself? Here we go again. None of these thoughts are sexual. It's distraction, 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 instead of focusing on the eroticism or sensual feelings. So the reason I use sensate focus is to try to get the man and the couple refocused on sensual feelings and try to diminish all of these distractions or performance anxiety. So I tell them right away that we're beginning with, you're not going to have intercourse. I'm going to take you back to sort of high school, college, where I just want you to touch. You don't have to get an erection. You're not going to have an orgasm. You're not going to have intercourse. And some people, of course, will say, well, what fun is that? But the point is, if you get people to do this, they recognize, wow, I can go back and do this and not feel anxious, not be distracted, and so on. You don't have to read the slide. I'll just tell you what I do. I sort of have the man and the woman, and I sort of ask who wants to go first. And if the woman wants to be the receiver and the giver, it depends. So she can be, in this example, the receiver. I tell her, you'll find a time where you're both sort of have at least a half an hour. Take your clothes off. Some people feel too anxious. I'll say, fine, leave your underwear on, or, leave a t-shirt on. But I want the man to start at the top of the woman's head and begin to caress her scalp, her back, gently, sensitively, but erotically. The goal is not a back massage, but to produce erotic sensations. Move your hands slowly and work your way down your body. Use your hands or your lips. Concentrate on how it feels to touch her body and skin. This is sort of a mindfulness aspect. That is, just think about, how does it feel to touch her shoulder, her back, her legs, and so on. After about 7 minutes or so, you don't have to time this, have her turn over, start again with the top of her head, avoid the breasts, and then work your way down the body. Then you take turns. Now during the time she's receiving, I say to her, I'd like you to communicate what feels good and what doesn't feel so good. So whether it's by sounds or saying that it's too hard to touch or that tickles, but let him know where it feels good, how it feels good, and so on. So that's her job. And then they switch and you say the same thing. He starts off lying on his belly, and she then starts erotically caressing his head, his back, his thighs, his feet. Do that for 7 minutes. Again, not a back massage. Produce erotic sensations with your hands or your mouth. He then flips over and again, starting at the top of his head and moving down to his feet. The goal here, again, is to produce erotic sensations. There's no need to have an erection. It doesn't matter if he has an erection or not. It's to get him to focus on the sensations of giving and the sensations of receiving, and to let her know what feels good and what doesn't feel so good. So that's sensate focus. Then I say to them, I'd like them to do that several times a week. I get them to agree to do it. And then when they come back a week later, how did it go? What worked? What didn't? And you'll sort of hear that often they don't make time for it in their busy schedules. And then we talk about the need to schedule. You're going to have unspontaneous scheduled sex. Do they make sufficient time for the exercises? What didn't work? What worked? Were they able to focus? And what else can they tell you? So you're sort of debriefing them about the experiences. You can then, once they are able to do this and really enjoy it, you can move on to sensate focus 2, which is including the breasts and the genitals. Again, there's no need for the man to have an erection or an orgasm, or for her to have an orgasm. It's simply trying to touch, produce erotic sensations in both, and to diminish the anxiety that they came into this with. So another technique that we use is stop-start. This was actually talked about by James Siemens, who was a urologist from South Carolina, written about it in 1956, and Helen Singer Kaplan, who wrote about it in 1983. This is a graduated behavioral exercise. And the point here is that most men with premature ejaculation tend to not focus on how aroused they are. They don't want to focus on their level of arousal because they fear, well, if I do that, I'll come more quickly. So we want to work them slowly from masturbation to some partner foreplay to intercourse. You want to resolve some of the interpersonal issues that may come up, and some of the intrapsychic, that's in his mind, issues, and address cognitive distortions that the person may be feeling. So again, you don't need to read the slide. I'm just going to tell you it. Again, I explained to men that, they're not usually focused on sexual arousal because they're afraid of it, but I tell them I want them to. Think of it like a speedometer on a car, where there's 0 to 10. 0 is absolutely no arousal. 4, 5, or 6 is a mid-range of arousal. 9 is the point of ejaculatory inevitability, and 10 is ejaculating. So I start these people on the idea of using a 0 to 10 scale, asking the man to begin masturbating in private to a 6. Then have him stop, allow his excitement to dissipate to around a 3, begin masturbating again to a 6, stop, allow it to dwindle to a 3, and then masturbate and have an ejaculation. The point of this is for men to focus in on their level of arousal and become aware of this. I ask them to do this several times a week for at least 2 weeks until they're very comfortable with this. The next step is, and that is if the partner will agree. And again, you don't want the partner to feel used or, in any way coerced, but you ask for the participation of the partner with the idea being, he hasn't treated this. He's beginning treatment. I understand that you may be resentful because he hasn't done anything for 10 years, but are you willing to participate and see if we can make things better? I also ask what she wants at the end of it. That is, she's going to provide some stimulation to him. Would she like him to offer some stimulation to her as well? So you begin with asking the partner to provide the man with either oral or manual stimulation, and he's then thinking about how aroused he is. To a level of 6, he asks the partner to stop. He waits for the arousal to dissipate. Again, restart the stimulation, go to a 6, stop again, and then the last time be able to ejaculate. Then, once the person has the mastery of this, I begin with what we call quiet vagina or no thrusting. He then penetrates the vagina and just stays there, no movement. Because he's associated the vagina, the wetness and the warmth with ejaculating quickly, I tell him to just stay there no matter how frustrating it is, not move. The same to her for 2 to 3 minutes. I tell him that he shouldn't get more than an arousal level of a 6. If he does, to withdraw and then start again. The point is to keep focusing on his level of arousal. Once he's gained some confidence in this, I suggest that they introduce some movement, but he's not to get more aroused greater than the level of a 6. So this is sort of stopping and starting. And this is very successful in helping the man recognize that he can control his ejaculation latency. And again, I think it also is helpful for the partner to feel like I've been able to help him as well. Another thing that we use in sex therapy is mindfulness. This has been around for a long, long time. And it's been a major addition to the psychological treatment arsenal for the treatment of anxiety, depression, substance use, and so on. The point of mindfulness is really to focus on being present and recognizing the sensations that you're experiencing, whether you call it a form of yoga, a form of mindfulness, and so on. And again, there are studies. Lori Brado did a study here with 79 women participating in 4 sessions of mindfulness. And the idea was to see if they could have a greater concordance between plethysmography, which measures sort of arousal in the vagina, and subjective arousal, what she was indicating she was experiencing. And after 4 sessions, women were able to demonstrate a greater concordance. These days, because of the pandemic, I see 90% of my patients via the internet. I see both couples and individuals online, and it's a really efficient way to see people. The license exemptions that had been in effect through about the beginning of this year allow me to see patients from other states. We have internet programs developed by academics to address ED, PE, and female sexual dysfunction. All of these are fairly successful. Now, I realize you may not do what we did at the Male Sexual Health Center and bring in a psychologist, although that's fun and nice. However, you could easily hook up the psychologist online to see your patient while you're seeing them and have a brief discussion and develop a treatment plan. Now, I've been saying for years that combining medical and psychological therapies is the way to go. Unfortunately, we're all trained to stay in our own lanes. There are now more than 20 studies demonstrating that combining brief psychological intervention, 4-6 sessions, and either a PDE5 or ICI is more efficacious than either treatment alone. Similarly, there are approximately 10 studies that report that combining brief psychological intervention with an SSRI is more efficacious than either treatment alone. As I said, we're used to staying in our own lanes, and it's hard to shift the way that we've been taught and the traditional models of sexual dysfunction. We need to broaden the way we look at this and how we work with our colleagues, whether it's physical therapy, in my case, urology, gynecology, family practice, and so on. That's it. Thank you for your attention. And let's see if I can get back here to this and see if you have any questions.
Any questions?
I was that crystal clear. That's good.
I have a quick question. I think a lot of patients, when you introduce the idea of sex therapy to them, they're either very for it or they're really not interested in it. What would you say is a good way to get them perhaps to consider going to sex therapy?
Well, I tell them that, again, this is what, if I were you, I might say, you recognize how this sexual dysfunction, whether it's a male or female sexual dysfunction, makes you feel. There's a lot of performance anxiety, pressure, distress, and you know that it affects the relationship as well. Sex therapy is a well-known tool to help decrease the performance anxiety, the distress, and improve the sexual function, and also improve pleasure and satisfaction. Again, people think, when they're given, my card by people here, they think I have two heads, or, that I'm going to watch them have sex or something. And the idea is, that if they're just willing to take the chance to speak with me, they often think that wasn't so bad. And by taking the history, just in doing that, it tends to make sense to them of, wow, I've really gotten myself tied in a knot here. I'm just so anxious. I'm so avoidant. I feel so down about this. And so that, there's a sense of you don't have a lot to lose to try it. I mean, it may cost them a little money, but there's not a lot to lose. And these are proven techniques that we have. So I would just encourage them to say that, this is a way of managing the psychological interpersonal side of the distress, the depression, the anxiety, and so on.
Thank you. That's really helpful.
You're welcome. Anything else? Anybody else? Well, I know it's late, and I greatly appreciate your taking the time to tune into this. I very much enjoyed having the opportunity to put this together, and hope that it was useful to you. So, Bobby, are we all set?
You are all set, and thank you so much, Dr. Althoff. We really appreciate that.
You're welcome. Good night, everyone. Take care.
All right. Have a great night, everyone.